Hello, this is the first video on male reproductive pathology. In this first little segment, I'm going to focus on looking at the assessment of male disorders, and then we'll talk about sort of an overview of male disorders, androgen therapy, look at phytoandrogens, and then even antiandrogens. So I'll go through that list. And then in subsequent videos, we'll look at male endocrine disorders, prostate disorders, and then male genital disorders. So I just want to say a few words about the male genital exam. You might have seen this in other courses, but I want to just kind of review some of the important points. The kind of obvious thing about the male genital exam is, first of all, that it should be done in a warm room. This is going to help to relax the dartos muscle, and that'll allow the testis to fully descend to make it easier to palpate. One of the first things you're going to do is just inspection, and that's going to be to inspect, for example, where the urethral opening is, if it's on the top side of the penile shaft, or if it's on the bottom side, and we'll look at hypospadias and epispadias in a later video. And then look at the angulation of the penis to see if it's abnormal. That's called chordee. Then usually measure the length of the flaccid penis from where the penis joins the abdominal wall and the skin to the tip of the glans. And then look at the normal size, volume, and consistency of the testes. So do a testicular palpation. And we're going to look for things like varicoceles, which I'll talk about later, and any other enlargement, tenderness, etc. And then palpate through the inguinal canal the spermatocords while the patient bears down with a Valsalva. So that's a typical kind of male genital exam. Couple of notes just for different stages of male development. In the fetus via ultrasound, one of the things we're looking at is the presence, for example, in the second or third month of any intersex characteristics. In the third month, looking at any defects with testicular descent, cryptorchidism, or unusually small penis. In the prepubertal years, for any signs of hypogonadism would be, for example, poor secondary sexual development, lack the development of the penis, the testes often remain small, the scrotum remains smooth. We might see these kind of disorders, and I'll talk about all the disorders causing hypogonadism in something like Klinefelter syndrome. The voice usually remains high-pitched, muscle mass doesn't fully develop, there's low strength and endurance, sparse axillary and pubic hair, absent facial, chest, and upper abdominal hair, and then the insulin growth factor from growth hormone continues to stimulate the long bone growth, so the upper and lower extremities grow, but these other sexual characteristics don't develop properly. And then signs of post-pubertal hypogonadism would be decreased libido, erectile dysfunction, low energy, facial hair growth diminishes, and usually there's a presence of fine wrinkles around the corners of the eyes and mouth, and that's usually a sign of excess estrogens. So these would all be kind of things to keep in mind when you're doing physical exam on teens, either before puberty or after, that might be indicators of hypoandrogenism. Now, some of the specific tests we use to assess male gonadal function, especially the hormone function, would be testosterone testing. And what we need to remember about testosterone is that it does follow circadian rhythm. So the levels are highest in the morning, and that's when we want to measure them, but usually between 8 and 11 a.m. And remember, there's a difference between total testosterone, which is equal to all of the bound testosterone plus the free testosterone. And it's the free testosterone, which is about, maybe 1 or 2%, which is what's available to the tissues. Remember, sex hormone binding globulin is the main binding globulin that binds up testosterone. So elevated sex hormone binding globulin, again, this is synthesized in the liver. And in the last video sets on the anatomy and physiology of the male reproductive system, we looked at all the factors like estrogen, which raise sex hormone binding globulin. So that's going to bind up more testosterone, making less free testosterone potentially available. So if we're going to get a total testosterone, sometimes they include in the test a sex hormone binding globulin level, and that'll help us estimate the free testosterone levels. We want to get usually 2 to 3 samples over time to give a good estimate. Usually what we do clinically, this is more the conventional approach, is to just get a total testosterone first, maybe with the sex hormone binding globulin, And then if that's low, then we get the free testosterone as an additional follow-up test. So we usually don't measure them together. And that's just because, for screening tests, you don't want to over test someone, and there's no need if the total testosterone is normal. So that's plasma testosterone, and that is a well-validated lab, and most major lab corporations will have that test. Salivary testosterone testing is not widely available. It's used a lot in the naturopathic and kind of functional medicine communities, and there are some specific labs that focus on it. It's considered actually maybe ideal because it measures the free hormone levels, and it's not invasive. You don't need to get a blood draw, and it can be done by the patient at home. So it's a lot more convenient. So I think over time we might see more tests shifting towards the salivary testosterone. One of the tricky parts of that is a lot of insurance doesn't yet cover salivary testosterone, but it will cover the plasma testosterone. So that's a little on testosterone testing. Additional hormones that are looked at for evaluating the male endocrine function would be luteinizing hormone. And usually, again, we get morning samples, at least 2 or 3, and that's usually taken at the same time that we get the plasma testosterone level. Prolactin, again, elevated prolactin. So prolactin in the physiologic range actually enhances the effects of luteinizing hormone in the testes. But supraphysiologic levels, like secreted in the pituitary adenoma, are going to shut down gonadotropins. And so we're going to get usually prolactin as well in the morning. And typically we have people just fast overnight and not eat breakfast. So eating can sometimes raise prolactin. DHEA, this is not a standard test to measure, but DHEA sulfate can be helpful for just looking at overall DHEA levels. In older, especially obese men, looking at estradiol could be helpful. Remember that aromatase, the main enzyme that converts testosterone to estradiol, is found in men primarily in adipose, and the levels of aromatase go up with age. And so we can see men getting very, very high levels of estradiol, which would give hypogonadotropic, low testosterone-like effects in the body. So that might be important to look at. And then in childhood, to see if we suspect failure of the testes or inadequate output of testosterone, there's something called the HCG. Remember, HCG, human chorionic gonadotropin, is a placental hormone produced during pregnancy. This is used for the evaluation of testicular function in childhood. Usually HCG, it acts like LH. It should stimulate androgen secretion from the testes. And so usually that's followed up with testosterone testing after the HCG is given. So that's a more specialized test. A few other tests we'll be talking about, like with the prostate, would be PSA, prostate-specific antigen, and I'll talk all about that in the prostate videos. And then, of course, urinalysis and urine culture would be tests we can do if we suspect infection and so forth. Semen analysis, I discussed that in the anatomy and physiology video, so you might want to go back and review that. Usually we only use this to check for fertility, but it can be sometimes used if we suspect just hypogonadism to see if a male will be infertile because of that, the low levels of testosterone. And then specific imaging tests for the male reproductive system would be Doppler ultrasound of the scrotum, and this would be checking for varicoceles or circulatory disturbances in the scrotum. And then we can do also what's called the transrectal ultrasound of the prostate. We call that a TRUS, and that will allow us to estimate the size of the prostate, and that'll be important for different prostatic disorders. Also, sometimes an ultrasound can be done on the lower abdomen to evaluate urine retention in the bladder. And so that would be important also if we suspect obstruction of the urethra and fluid buildup in the bladder. And then a CT or MRI might be needed, especially with like prostate cancer, looking at potential metastases. So that's just a quick summary of some of the basic tests we'll be encountering as we look through the different male disorders. Now, I just want to say a few words about treatment of specifically hypoandrogenism, and we'll look in a minute here at androgenism, like PCOS in females. But with hypoandrogenism, we have to first of all establish what the diagnosis is, and we'll go through that in the next little video. We can have problems with the testes themselves or with the, pituitary, etc. So we need to differentiate those. But we want to look also at establishing what level of the therapeutic order is needed for treatment. And that's going to really depend on the condition causing the hypoandrogenism. Usually for things like andropause, and that's where just over time with age, testosterone levels go down with males. We're going to focus more on level 1 and level 2, the therapeutic order. Level 3 replacement therapy is going to be really reserved for cases when the low androgens are going to have really adverse outcomes. For example, in maybe a severe Klinefelter case where you might see, lack of proper sexual development because of that. And so we might see androgen replacement therapy given for that. But that said, androgen replacement therapy, a lot of functional medicine doctors give this a fair amount, but I tend to be more conservative personally. Again, we're all going to approach it differently. But I tend to find that the level 1, level 2 therapy, especially the herbal therapies, can be very effective at improving androgen function in men. Level 4, addressing pathogenesis, really isn't going to really have a place in hypoandrogenism, except maybe if we have like a prolactinoma or something like that that needs to be surgically corrected. I'm not going to talk about testosterone for gender reassignment for female to male transition. That's a kind of a specialized topic, partly because we're using, in that case, supraphysiologic levels of the hormones. And that kind of involves a whole different thinking around that. So I'm going to just approach more the typical conditions we'll see that might require low androgens. We might need referrals depending on the condition to endocrinology or so forth. So we'll go through that with each one. But I just want to give a couple of pointers for hypoandrogenism, looking, for example, at diet. A lot of times we find that one of the most common reasons why men, especially as they get older, have lower androgens is just they have a very high inflammatory diet. And one of the things that can happen is that endothelial dysfunction, which again is a hallmark of cardiovascular disease, results in less blood flow to the testes, and that's going to compromise testosterone production. So improving the diet with anti-inflammatory foods, antioxidant foods, a lot of vegetables, fruits, whole grains, that sort of thing, is going to be potentially helpful for protecting endothelium. So that's one area. Exercise, really this use caution isn't necessarily applicable here. We want to, with exercise, encourage good blood flow. So in general, mild to moderate amounts of exercise are very helpful. Over-exercising can certainly create problems with hypoandrogenism. Had an interesting patient who was a pilot, and he actually presented with a problem where he was having high blood pressure, and the way he actually managed his blood pressure was through running. But every time he would run, he'd get horrible calf cramping, and the airlines wanted to put him on medication. If he didn't reduce his blood pressure, he would lose his ability to fly. So we kind of worked him up, and it turned out his testosterone was quite low. So I started him actually on DHEA replacement, because he wasn't interested in herbal therapy or anything. And it was remarkable how he could now run without cramping and those different things. So having low androgens can, really inhibit exercise, but getting the androgen levels stabilized, maybe with a level 2, in some cases level 3 therapies, can be helpful there. We do know that definitely smoking, excess alcohol, inadequate sleep with low melatonin, all of those will impede androgen production. And then certainly stress, HPA axis overactivation can affect that as well. So we want to address all of those at level 1. Level 2 therapies, there's a couple of major herbal classes that we want to look at. Probably the two most important I use for low androgens will be phytoandrogens and stimulant adaptogens. And I'll talk about the phytoandrogens here. We looked at the stimulant adaptogens with the adrenal section already. Those are probably the two biggest groups of herbs that can be used to increase testosterone levels. That said, we have to look at the whole picture. So men who are really anxious, have a lot of sleep disturbance and whatnot, there we might need to use, nervines or sedative adaptogens. With insulin resistance, we might need to use insulin sensitizers and so forth. In Chinese medicine, if you're a Chinese medicine practitioner, there are certainly different patterns. And probably the biggest pattern connected with low androgens is kidney yang deficiency. So I'll talk about that a little bit coming up here. But that's treated again with the kidney yang tonics in Chinese medicine, which in the Western parlance are the phytoandrogens. So I'll come back to that. And then we know there are different nutrients. A lot of them are similar to what we saw with the adrenal, vitamin C, B5, potentially D, zinc, selenium, and so forth. All of these are important for normal testosterone production. So that's level 2 therapies. Level 3, replacement, and this would involve replacement either of testosterone, and that's called androgen replacement therapy, ART, or DHEA. There's really no clear guidelines. Generally, though, in men, if I'm going to use DHEA, I usually use a fairly low dose, 10 to 20 milligrams per day. Some use up to 50 and 100. And I think some safety studies have looked up to 200 milligrams a day and found no adverse effects. But that's something we need to be careful about, is overdosing that. But maybe 10 or 20 milligrams per day could be considered a good starting dose for DHEA. Pituitary hormones are sometimes given in extreme cases if we need to, like GnRH, LH by injection. But androgen replacement therapy, a couple of words here, and I'll go into the next slide in more detail on this. But basically, oral testosterone is not used. So that's one clear thing we need to keep in mind. That has a high incidence of liver toxicity, raises liver enzymes. It also increases your clotting proteins and increases your cardiovascular risk. So oral testosterone, although available, should not be used. There's no upper age limit in starting therapy, but I'll talk about on the next slide some of the things you need to look out for, and some of the exams you need to have completed before a patient starts on testosterone replacement therapy. But the main forms we have are gel. This is a preferred agent. It's more expensive, although the price is coming down. This more closely mimics physiologic dosing because you can put on the gel in the morning. It's absorbed at higher levels in the morning, and then the levels drop off during the day, which is how testosterone is normally secreted. Generally, we use 5 grams, which equates to 50 milligrams of testosterone per day. The problem with this is skin-to-skin transfer. So with a male and his partner, any close contact and any contact of that gel can transfer to the partner and be absorbed through the skin, and also children. So we have to be careful. And some of these, like Androgel, Testim, and whatnot, some of them are available as an underarm, like almost like an underarm deodorant stick, and usually that avoids any of the skin-to-skin contact. Injection is another form. So this is given IM, 200 milligrams every 2 weeks or 400 milligrams every month. And so that's depot testosterone. So these are still used, although I think the gels are kind of becoming the preferred agents. Again, they're a little easier to use. There is a testosterone patch, and that's 5 milligrams applied nightly to the thighs or the torso. Again, this will mimic physiologic dosing. This Androgen and Testostim are examples of that. And then buccal, so in the mouth, absorbed sublingually. And Striant is an example of that. That's 30 milligrams to the gum region, but that has to be taken twice a day. Not quite the same as physiologic dosing. And then there's a nasal. I don't know if this is still in production, but Natesto. It's a nasal testosterone gel, but it has to be taken 3 times a day, so not convenient. And then probably the most popular thing I've seen recently are the implantable pellets, so Testopel, and this implant is given every 3 to 6 months. Again, this is not physiologic dosing, and I've actually seen now a number of female patients who are receiving this, and I'll remember that there is a role of testosterone in females, we think, especially for supporting energy, but also libido and sexual function. So I've had several patients really claim that they improved after they received the implantable pellets. All right, so that would be an overview of androgen, kind of for hypoandrogenism, how we might think about using the therapeutic order to support that. So I want to say a few more words about androgen replacement therapy. Again, this includes testosterone replacement and DHEA, although in most textbooks it mostly just refers to testosterone replacement therapy. The indications for ART would be in males for male hypogonadism, as we just discussed, that's androgen deficiency. And that could be primary, meaning that the testes are not putting out androgens, or secondary, meaning that the LH, FSH from the pituitary or GnRH from the hypothalamus are not properly secreting and not properly stimulating the testes. There can rarely also be androgen receptor genetic defects, which results in androgen insensitivity. So all of those would potentially be roles for androgen replacement therapy. Transgender men would be another indication, and that's part of the masculinizing hormone therapy. In females, again, the role of androgens is still being researched, as I discussed in the anatomy and physiology videos. But one indication would be hypoactive sexual desire disorder. And there could be, and this is again being explored, benefits for the cardiovascular system, for bone, for brain health and muscle mass, etc. And then potentially in breast cancer treatment, because giving the androgens have anti-estrogen effects. Again, we have to probably give that alongside an aromatase inhibitor to prevent aromatization of those androgens to estrogens. Non-medically, androgen replacement therapy is used in athletic performance enhancing. This is not an approved or recommended use. For males who come wanting to enhance their androgen activity, I personally clinically focus again on the level 1, level 2 therapies and don't recommend androgen replacement therapy unless there's actual evidence of hypoandrogenism. Again, on the right here is a table of all the different forms of testosterone therapy we just went through, but the most popular being the gels and potentially the implantable pellets. Some considerations about androgen replacement. So again, we don't use oral testosterone because of the effects it has on the liver through first pass metabolism, increasing clotting proteins and increasing liver enzymes. Topical agents are preferred, but they are more expensive than the injectables. So that could be an issue for some people. But typically with most insurance companies, if there's an indication for androgen replacement, it should be covered. Prior to starting therapy, we need to get in the patient's history a complete voiding history. So are they having any urinary frequency, urgency, any dysuria, any dribbling, nocturia, difficulty starting the stream. We want to get their blood pressure, a digital rectal exam. I'll go over that with the prostate section. And then a sleep apnea history. Testosterone therapy is actually contraindicated in patients with obstructive sleep apnea. So that's something we need to rule out first. Baseline labs would be to get a PSA, the prostate-specific antigen, fasting lipids, because too much androgen can actually drive up the LDL and increase cardiovascular risk, a CBC, and that's because androgens will increase hematocrit, and then liver function tests. And then we want to recheck the morning testosterone levels after starting therapy, usually within 2 to 3 weeks if it's a gel, a patch, or if it's the buccal form, or 8 weeks if it's the injectable form of testosterone. At 3 months, the patient should return. We gather another voiding history, blood pressure, do a DRE again to make sure there's no prostatic enlargement. We want to repeat blood tests and a morning testosterone level, and then look at any improvements in the symptoms, sexual function, energy, muscle mass, and so forth. If there's no change in the labs or the findings, then we follow every 6 months with repeating a DRE, PSA, BP, voiding history, and testosterone levels. Now, contraindications to testosterone replacement will be prostate cancer. It's a complicated thing with prostate cancer. It turns out having low testosterone increases a man's risk for prostate cancer, but once the prostate cancer has developed, it can accelerate the growth of that cancer. So this is a little more complicated. Any evidence of elevated hematocrit over 54%, that's the upper range of hematocrit in normal males, and then any uncontrolled congestive heart failure, and again, uncontrolled obstructive sleep apnea. So these would all be potential contraindications for therapy. Adverse effects really are going to depend on the dosage. but typically they would involve fluid retention, acne, sleep apnea again, and then potentially liver toxicity is, again, highest with the oral agents, but it's possible with other agents as well. The biggest worry people have, again, are cardiovascular risks for taking testosterone. And again, it's complex. This is hormesis, where normal physiologic doses secreted by the testes seem to have protective effects on endothelium, on cholesterol levels, and so forth. But we get super physiologic doses, which you can get, unfortunately, with the replacement therapy. Especially, we can see spikes of testosterone that can actually increase cardiovascular risk. So the evidence is really conflicting out there depending on the dosage level that people are using. But typically, the negative effects of testosterone could be to increase LDL and triglycerides, and that would increase stroke risk, and then increasing hematocrit as well. So that would be increasing your RBCs, causing polycythemia. And that might actually require phlebotomy at periodic intervals if it's severe enough. And there's an increased risk of blood clots, DVT, and just thrombosis in general. So these would be the negative effects. On the prostates, the testosterone could potentially enlarge the prostate, worsening BPH. I put a question mark there because that is unclear at this point. But we do know that if there is prostate cancer already growing in the prostate, adding testosterone is like adding fuel to the fire. However, if there's no prostate cancer, just regular BPH, it could be that having low testosterone would increase your risk of prostate cancer. So if we improve the testosterone levels, that could make a difference. I'll go through all that with the prostate discussion because it also involves not just testosterone, but remember the most active form of testosterone is dihydrotestosterone, and the enzyme that converts testosterone to DHT is 5-alpha reductase. And when that's upregulated in the prostate, we start to get that more aggressive form of testosterone, which can cause the prostate to grow. We also see that the aromatase levels go up in men, so there's higher estradiol. So one of the theories that it's actually higher estrogen with high DHT and low normal testosterone that actually predisposes one to prostate cancer. That's just the theory right now, but that's kind of where some of the evidence is. In the testes, high testosterone or supraphysiologic levels can actually induce oligospermia or azoospermia, so decrease the sperm numbers and sperm counts, and then cause testicular atrophy and shrinkage. And we see this, for example, in steroid abuse in athletes. It actually causes the testes to become very small, and a man will become infertile with those supraphysiologic doses. Again, there are other effects, aromatization to estrogens that could cause gynecomastia, as well as abdominal fat deposition, and then conversion to dihydrotestosterone could cause prostate enlargement. So those are some of the adverse effects to think about, and this is why I don't like to start with testosterone replacement or in a let's say an older man with low testosterone. I'm going to start with level 1, level 2 therapies to see if we can get the levels up. And in most cases, I find that's enough. I have a few patients where that doesn't work, and then I usually switch to DHEA, try that, because that's sort of a proto-androgen, remember. And then we try that for 3 to 6 months. And if that doesn't work, then I consider the testosterone replacement if it's really indicated. So I mentioned a few times this herbal category of phytoandrogens. Let me say a little bit more about that. These are also known in Chinese medicine as kidney yang tonics. This orange-red here I have in my notes, this is my own way of doing herbal medicine. I tend to find that herbs have different, you could say, inner physiologic colors, any inner activation of the forces that they activate in physiology. Orange-red really means they increase metabolism, circulation to tissues, and so forth. So that's what that indicates there. Now, phytoandrogens include herbs like Panax ginseng, epimedium, tribulus, eucomia, serenoa, that's the salt palmetto, nettle root, smilax, maca. I put a question mark there because there's also estrogenic effects of maca, but that's probably because it raises androgens, which then get aromatized to estrogens. Trigonella, Tongkat Ali, Mirapalma, Demiana, and Pygeum. Now, these all work through different mechanisms, so I've kind of just broadly put them into this category. Minerals, metals like selenium, iron, zinc, also I'm putting in this category of supporting androgen production, and then nutrients like vitamin C and B5. Now, what do all these do? Well, essentially they support the HPG axis. They address states of metabolic insufficiency, which come from low testosterone. You've probably heard the word low T. That's used in the pharmaceutical marketing industry to describe low testosterone states. That is really what in Chinese medicine is called kidney yang deficiency, same thing. And this is regulated by the androgens, especially testosterone, but also DHEA, through various mechanisms. So if we get a little bit more detailed about the chemistry of these, there's a broad group of constituents, but probably the most important would be the triterpenes and the triterpenoid saponins. So these all, you could say, have a cholesterol backbone, and they're going to work on several places on the HPG axis. So the first grouping would be the cognate phytoandrogens. And there's an interesting article I've mentioned here you might want to look at that was published in the Chinese Journal of Natural Medicine in 2014. That kind of goes through the chemistry of these and analyzes them. But cognate phytoandrogens are essentially androgen receptor agonists. So tribulus and eucomia both have protodiosine, and protodiosine, a triterpene, is actually an androgen receptor agonist. There are phytoandrogenogenics, and these essentially are regulating the HPG axis by increasing LH secretion. And they're probably also slowing down the elimination of androgens through metabolism. Some of them are aromatase inhibitors, and some of them regulate the sex hormone binding globulin. So nettle root, for example, we think downregulates sex hormone binding globulin production in the liver, and that's going to result in more free testosterone to the tissues. There is a third class here, the functional androgen mimetics. And these cause the same physiologic action of androgens, but don't actually raise testosterone or bind directly to androgen receptors. So for example, Demiana, we know, increases the parasympathetic stimulation to the penis, so it increases more nitric oxide release, and that'll help with erections. Icarin from Epimedium is a PDE5 inhibitor, just like Viagra, Cialis, etc., and that also will increase the nitric oxide. So these have, we could say, androgen effects, but not directly by increasing testosterone. And that's why studies that look at these and like, yeah, these don't raise testosterone at all, that's because they're not really working through that. They're having secondary effects. And then we can say in general, these have general tonifying effects on the body to increase general immune activity, insulin sensitivity, and kidney function. That's an interesting finding. I've seen men who have been put on androgen suppression therapy for prostate cancer. I'll talk about that in the prostate section. Develop within a short period of time, a couple of months, essentially diabetes. And that's kind of shows how important how androgens are for insulin receptors and insulin sensitivity. So this is where it gets really complicated. Working with insulin sensitivity, let's say pre-diabetes or early diabetes in an older man, might not be just a case of giving insulin sensitizing herbs. Bitter melon and gymnema and maybe chromium, things like that, but also working with androgens. And I've found many cases where the typical kind of blood sugar lowering products on the market don't really help these older men, but when we get their androgen levels up, now suddenly their insulin levels improve and their dysglycemia resolves. So those would be some of the interactions there with the androgens. So the tissue states we can say these herbs treat really are, the low testosterone picture, maybe low DHEA, and that often manifests with cold limbs, hair loss, severe fatigue, asthma, and that's because both DHEA, testosterone especially DHEA, have tonifying effects to the respiratory tissue, preventing bronchodilation, improving respiratory blood flow, decreasing fibrosis. Copious, clear, frequent urination is often, these are really symptoms of LUTS, lower urinary tract symptoms, and we'll discuss those in the prostate section. Low libido, erectile dysfunction, anemia, unexplained anemia, especially microcytic in an older man. Of course, anemia in a male at any age, the first thing we need to think about is there an intestinal bleed? And often that can be from an ulcer or from cancer. And so we need to make sure that's been ruled out first. But unexplained anemia in older men often responds to testosterone therapy. And then BPH, again, might be in chronic prostatitis, might be related to low androgen states. Again, we'll discuss that later. Chinese medicine, interestingly, has this pattern called kidney yang deficiency, which essentially has exactly the same symptoms. So I just put those side by side to show that, we have different descriptors in different medical traditions, and it's important that we learn how to make connections so that we, for example, in the clinic aren't giving a patient testosterone and they see their Chinese herbalist and they're getting kidney yang tonics, and that's maybe doubling up on the same therapy. So it's important to understand, the different links there. All right, so that's a little bit about phytoandrogens. So we talked about therapies that increase androgens. Now I want to just say a few things about anti-androgen therapy. These are androgen antagonists, and they essentially prevent androgens from mediating their effects. This is a complex class of drugs because there's many different types, but they're basically used in males in the treatment of prostate cancer, BPH, androgenic alopecia, that's a male pattern hair loss, hypersexuality, priapism, and then early puberty. So those would be indications in males. In females, usually we use anti-androgen therapy with PCOS, and that would be, states with acne, increased seborrhea, hirsutism, any sort of hyperandrogenism manifestation, and then breast cancer treatment, again, is potentially anti-estrogen therapy. And it's used, the anti-androgen therapy are used in transgender females as part of the feminizing hormone therapy to block essentially the actions of androgens, especially pre-pubertal. So those would be some of the indications for the androgen antagonists. Now they fall into different classes. So there's the direct androgen receptor antagonists, and they can be either steroidal or non-steroidal. The steroidal would be things like spironolactone. Now we usually think of this as blocking aldosterone in the kidneys, in the effects of aldosterone in the kidneys and the body, but they also has anti-androgen effects. Cyproterone is another example. The non-steroidal would be things like flutamide, and again, these are all going to block androgen receptors. Some progestins in high doses will do that as well. There are androgen synthesis inhibitors, and we saw one of these already with the adrenals, and that's ketoconazole. That's a CYP17A1 inhibitor, so this blocks steroidogenesis in the testes. And then there are 5-alpha reductase inhibitors, which are going to block the conversion of testosterone to dihydrotestosterone. So they're not true testosterone inhibitors, but they're blocking that more active form. And that would be the classic ones, finasteride, Proscar. There's a form of this available for the male pattern hair loss, and that's called Propecia. There's dutasteride, Avodart. And this is where you hear of a lot of natural products like zinc, saw palmetto, pygeum being also having 5-alpha reductase inhibitor activity. It's a challenge though, because working out the actual dosages and how an individual male will respond to the herbs as pure 5-alpha reductase inhibitors is complicated. So that's why the conventional sources don't usually mention these. And the data has been fairly weak with prostate cancer and so forth that these have a benefit. Now, we'll talk about these. These used to be a fairly main part of treatment for prostate cancer, but they're becoming less favored. I'm sorry, for BPH, not prostate cancer. For BPH, they're becoming less favored because we now just use the alpha blockers. And again, I'll talk about that in the prostate section. Final androgen antagonist here would be the GnRH antagonists or agonists, and they're basically going to interrupt the pulsatile rhythm of GnRH, and that will decrease FSH and LH, and that will result in less testosterone and then downstream estradiol, and that usually induces hypogonadism. So these used to be called sometimes chemical castration agents. They essentially castrate the gonads by shutting off the gonadotropin production. And the uses here would be for prostate cancer, breast cancer, endometriosis, uterine fibroids, and early puberty. So used in both males and females. Examples here would be the leuprorelin, and that's Lupron, and the cetrorelix. So Lupron is probably the one I've seen used most commonly, like for prostate cancer. And the male I mentioned earlier who developed diabetes after prostate cancer treatment was actually on this medication. These are given by IM injections, and this essentially is a GnRH agonist, and by agonizing that receptor at these high doses, it actually shuts it off. So kind of an interesting phenomena. So that is another way of inducing anti-androgen effects. Obviously, the adverse effects of this in males would be blocking off androgens, and from that we might see more osteoporosis. Remember that androgens have a very important role in supporting bone health, especially in males. So male osteoporosis is often from low testosterone. In females is usually from low estrogen, but again, that estrogen is coming from testosterone. So you could say there's a role of testosterone in females as well. More feminization, gynecomastia, sexual dysfunction, infertility, depression, fatigue, anemia, hot flashes, and hepatotoxicity. So these would be unfortunate adverse effects of that. Not to mention having low androgens are going to maybe induce metabolic syndrome, poor endothelial function together with dysglycemia, and then increase abdominal obesity from essentially, when you shut off androgens, you're going to decrease estrogens, but the ratio, interestingly, often what we start to see is the ratio between testosterone and estrogen goes down. So we get less testosterone, but more of it's going to be aromatized over to estradiol. So we're getting relatively higher estrogen, which is why some of these are hyperestrogen effects. In females, the antiandrogens are contraindicated in pregnancy for obvious reasons. It's going to shut off the important hormones there. And the adverse effects will be similar to those seen in males. So that's a little bit on anti-androgen therapy. Okay, so that kind of wraps it up as an introduction to the different disorders we'll be looking at. In the next video series, we're going to jump into the kind of endocrine disorders of the male reproductive system.